Welcome everyone to today's webinar. I am Tracy Cook with Sachs Healthcare Communications, and I'll be your webinar producer for today's webinar on safe and efficient anesthesia, the role of quantitative neuromuscular monitoring. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the GoToWebinar control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. Our moderator for today's webinar is Dr. Leewald. Dr. Leewald is a senior anesthesiast at the Department of Anesthesia and Intensive Care Medicine at the Technical University of Munich, Germany. Scientifically, she focuses on basic and clinical research of the neuromuscular junction, as well as the pharmacodynamics and kinetics of muscle relaxants, as well as the reversal agents. Her research work has been awarded with numerous prizes. Dr. Leewald is an enthusiastic teacher for residents, medical students, and nurses implementing modern concepts knowledge transfer, such as e-learning, patient-based learning, etc. As a CRM instructor, she also teaches in simulation-based settings. Dr. Leewald, welcome.
Well, thank you so very much, Tracy, for that really kind introduction. And thank you to GE Healthcare for providing support for this educational activity. Now, the title of today's webinar is Safe and Efficient Anesthesia, the Role of Quantitative Neuromuscular Monitoring. And we are very fortunate to have two extremely qualified speakers today presenting on this very important and timely topic. Now, our first speaker is Dr. Manfred Blobner. Dr. Blumner is a professor of anesthesia and intensive care medicine, a senior consultant, and the vice director of the Department of Anesthesiology and Intensive Care Medicine at the Technical University of Munich. During the last 26 years at the department, he inaugurated and chaired 7 clinical and experimental research groups. He currently leads a research group on neuromuscular physiology and pharmacology and is the chief investigator of the European Society of Anesthesiology's clinical trial network study, POPULAR. Dr. Blumner is the author of 148 manuscripts published in several international peer-reviewed journals and has been invited to many international medical conferences. Our second speaker is Dr. Matthias Eickermann. Dr. Eickermann is a professor of anesthesia at Harvard Medical School, attending anesthesiologist and vice chair of faculty affairs in the Department of Anesthesia, Critical Care, and Pain Medicine at Beth Israel Deaconess Medical Center. A major focus of Dr. Eickermann lies in the pharmacophysiology of neuromuscular transmission, as well as postoperative respiratory complication and patient-centered outcomes. Dr. Eickermann serves as the associate editor of the British Journal of Anesthesia. He has published over 200 papers in many peer-reviewed journals. And Dr. Eickermann is also a highly sought-after speaker and has presented at over 100 medical conferences throughout the world. Disclosures: Manfred Blobner has disclosed the financial relationships to MSD, Grünenthal, both in Germany, as well as GE Healthcare in Finland. And Dr. Eickermann has disclosed financial relationships to Merck as an investigator, and is also a patent holder for calabodions, reversal agents for neuromuscular blocking agents, and drugs of abuse. A link to obtain CME credits will be available at the conclusion of this webinar. And this activity is jointly provided by Synaptive and Sachs Healthcare Communications. The accreditation statement is listed below for you to read, and support for this educational activity is provided by GE Healthcare. This educational activity is approved for 1 contact hour of CNE and CRCE, and again, the accreditation statement is listed here below for you to read. Now, I would like to turn over the presentation to my very dear friend and colleague, Dr. Blobner. Manfred, please.
Thank you very much, Heidi. I would also like to welcome everybody to the webinar about neuromuscular monitoring today. Indeed, the quantitative technique is a very important approach in terms of patient safety and efficacy in anesthesia. Therefore, Dr. Eickermann and myself will present the role of quantitative neuromuscular monitoring in anesthesia. Let's start our discussion simply by questioning its need. And to make it more vivid, I would like to introduce Julia. Julia is a morbidly obese ASA3 female patient undergoing emergency laparoscopic sigmoid resection. She is anesthetized with propofol and paralyzed with rocuronium. Thanks to 2 increments of rocuronium, the surgeons have been able to complete the sigmoidectomy. Approaching the emergence of anesthesia, the anesthesiologist measures the neuromuscular function using a nerve stimulator. The anesthesiologist feels 4 responses to the 4 twitches without any effect. Matthias, what do you think? Is Julia ready to be extubated based on these findings? I can't hear Dr. Eickermann.
Dr.
Okay.
Eickermann?
Yes,
Thank you.
I'm unmuted now. Sorry about this. So Manfred, in order to get extubated, of course, several criteria will need to be assessed. For example, recovery of consciousness and muscle strength. But as far as reversal of neuromuscular blocking agent goes, the trainer-4 ratio is the golden standard, but it's not good enough to look at the fate of contraction. So here is a paper that was published in 1984 by one of the pioneers in clinical neuromuscular transmission assessment, Jorgen Wiebe Morgensen. And it shows on the x-axis the recovery of the trainer-4 ratio from 10% to 100% TOF ratio of 1. And the y-axis is showing the detectable fate, comparing 2 techniques, the trainer-4 fate and the double burst fate. And you can see, if you look at the trainer-4 curve now, that, for example, only 50% of the patients, the clinicians, were able to identify a trainer-4 ratio, which is still at 0.5. Problem is that our eyes and also our hands, when we measure it tactilely, are not sensitive enough to identify trainer-4 ratio of 50%. Next slide, please. Here's another paper that basically shows that there's a difference between the tactile assessment and the quantitative measurement of the trainer-4 ratio using accelerometry, AMG, here in this graph. You can see if clinicians use only the tactile assessment, then the trainer-4 ratio measured quantitatively can vary between 30% and 120%. And the other little table here in the slide shows that basically when you used in that study the quantitative method AMG, then you didn't see any respiratory problems. I mean, the study results are almost too good to be true, but I think the trend is clear. If you measure it only tactilely, then you have problems. Here in this study, between 4% and 21% of the patients had some issues that potentially reflect inadequate recovery of respiratory function. Next slide, please. So before we go into more detail, I think it's important to look at some definitions. There was a consensus paper published last year in Anesthesia Analgesia, and I think we can use those definitions here as we move forward in the webinar. Complete block, deep block, up to minimal neuromuscular blockade. And you can see that for all those definitions, you need to use quantitative measurement of the trainer-4 ratio. Other than that, you cannot really discriminate between a so-called minimal neuromuscular block, which can be a TOF ratio of 0.4 to 0.9, or acceptable recovery, which we believe is a trainer-4 ratio of 0.9 or even better, 0.95. Next slide, please.
Thank you very much, Matthias. I completely agree that only quantitative but not qualitative monitoring provide accurate information about residual neuromuscular blocks. And importantly, again, it's between zero point 0.4 and zero point 0.9 where the story will be decided. Matthias, some anesthesists claim that using a simple nerve stimulator plus giving a reversal agent is an effective combination to provide sufficient recovery. Julia's anesthesiologist at least considered and believed in that approach. He gave her 2.5 milligrams neostigmine. Matthias, is Julia now ready to be extubated?
Same statement still counts. In order to be ready for extubation, the clinician needs to assess several variables. But I want to go a little bit in more detail to see how much neostigmine really reliably helps us recover the train of 4 ratio to an acceptable value, which, as we already discussed, indicates an acceptable recovery of neuromuscular transmission. This is a paper also already 17 years old, same group of people, small study in about 50 patients. The authors measured neuromuscular transmission on both arms, right and left arm. And then they, in 4 different groups, they injected neostigmine, 70 mics per kg, and at a recovery of a train of 4 count to 1 or 2 or 3 or 4. And as you can see, first, the time to recovery of the train of 4 ratio, quantitatively measured to 0.9, it's pretty variable. So on average, it's like 17 to 22 minutes that it really took. However, you can see that the variability is pretty high. And also I want to point your attention to the very high values of recovery of train of 4 ratio in up to 143 minutes in the group of patients who had a train of 4 count of 4. And that leads to another problem that we have with neostigmine. If you have already a patient that has been recovered completely from your muscular transmission block and give that high dose of neostigmine, then you can actually induce a neuromuscular blockade rather than improve the neuromuscular transmission. And that can be explained by a depolarizing neuromuscular blockade that can be seen with neostigmine doses in patients who don't need really the neostigmine. Next slide, please. So this is one of our studies that was just published ahead of print in ANA this year. Basically MGH data, we wanted to look, this colleague and friend of mine, Stuart Foreman, had the idea to examine what really happens with neostigmine and glycopyrrolate reversal with heart rate and blood pressure. And we compared a couple thousand patients who did not get reversal. About 1/3 of the patients don't get reversal in that clinic, in that observation period, Mass General Hospital, versus those who got neostigmine. And you can see that clearly the odds of bradycardia and tachycardia are both increased in patients who received neostigmine glycopyrrolate. Well, we then went ahead and looked, does that really lead to severe cardiovascular complications? Well, that was not the case consistently, only in very vulnerable patients who had a high risk of cardiovascular complications. In those patients, we saw that the tachycardia basically was leading to an increased risk of cardiovascular complications. So the combination of neostigmine and glycopyrrolate, and all anesthesia providers know that, lead predictably to problems with heart rate. Next slide, please.
These problems obviously seldom appear when Sugamadex is given, but in terms of activity, even Sugamadex is not completely predictable. This study performed by Kotaki and colleagues demonstrated that. In their study, they have given reversal agents without using any neuromuscular monitoring to define and to calculate the dose of neostigmine and Sugamadex. Expectedly, 2.24% of their patients receiving neostigmine arrived at the PACU with a train of 4 ratio below 0.9, and with a train of 4 ratio below 1.0, it were 67%. However, even the very effective reversal agent Sugammadex was not able to avoid residual blocks when given without calculating the dose according to the block. 4% and 45% of the patient arriving at the PACU with a TOF ratio below 0.9 and 1.0 respectively. But let's see what's happened next with Julia. The acceleromeographic reading displays a TOF ratio of 0.9 before Julia is extubated and transferred to the PACU. There, however, her oxygen saturation drops to 72% and she complained about dyspnea and muscle weakness. Therefore, her ventilation is assisted by a non-invasive CPAP device. And indeed, an EMG reading shows the discrepancy between the AMG and TOF ratio. Matthias, please comment and explain us this finding.
Well, next slide, please, Manfred. You know, this is a study that we conducted last year, and it was published this year in the Irish journal Anesthesia. We were interested in looking into the consequences of an intraoperative desaturations. I mean, we anesthesiologists see this all the time, that patients desaturate, and of course we could ask ourselves, so what? And if a patient desaturates, you just do something and give a little CPAP, and everything is going to be all right. However, what we found, and a little bit surprisingly, is that there's a robust association between intraoperative oxygen desaturations and postoperative complications. So for respiratory complications, which we used pneumonia, ARDS, and reintubation, there was an odds ratio of 1.68, which means a 68% increased risk, and even higher when the saturation was a little bit more profound. And for ICU admission, similar observations, so 35% versus 70% increase in risk with increasing oxygen desaturation. So we don't know exactly if that's a cause or cause-effect relationship, or if it is an indicator, but we do know that intraoperative desaturation is not a piece of cake. And so what is the wrong answer to it? Next slide, please.
Yep.
So in this study, which we published also this year in ANA, we looked at a cohort of patients where we had very nice train of 4 readings in the postoperative recovery room. So that we did not do supramaximal stimulation, just we used 25 milliamps, so that's not really painful. So we got train of 4 readings in the PACU. And then we were looking into not only the association between muscle relaxant dose and outcomes, but really the direct consequences of residual neuromuscular blockade. And you can see that both in crude analysis and also in adjusted analysis, the residual neuromuscular blockade is associated with adverse consequences, particularly postoperative intensive care unit admission. There was a 3-fold admission rate in patients who had residual neuromuscular blockade. The costs were not really different. Costs calculations are complicated, but we also found a marginally significant increase in the postoperative hospital length of stay in patients who had a partial paralysis in the recovery room. Next slide, please. So there's another study which is interesting. It's an old study also from Glenn Murphy from Chicago, where he did a cohort study, and he looked specifically in 7,500 or so patients to identify those who had critical respiratory events in the PACU. And then he created a matched cohort of patients who who did not have those critical respiratory events. And then he compared the neuromuscular transmission between those two groups. And you can see here at the first glance that basically in the patients who had critical respiratory events, the substantial amount of patients had really a lower train of 4 ratio than 0.7. And whereas in the matched controls of patients who did not have any respiratory problems, they didn't observe those neuromuscular transmission impairments in the recovery room. Next slide, please. So we did that study that was published in 2012 in the BMJ, and I must say this was heavily criticized by many, many people and raised a long-lasting discussion, which was finished no earlier than last year with Manfred's study, which he's going to show you in a minute. So what did we do? We looked at the relationship between the use of neuromuscular blocking agents versus not. As you all know, you can do anesthesia and provide surgical conditions without using muscle relaxants. Actually, we did not count succinylcholine given for intubation as a muscle relaxant. We only looked at the non-deprolizing neuromuscular blocking agents. And then we looked at postoperative desaturation and reintubation risk. And you can see there's about 20 to 50% difference in desaturation and reintubation between those who received neuromuscular blocking agents for surgery and those who did not. And we have controlled that for several variables. I really believe in the data. Manfred has supported in a study that he will show us, and we have another study underway, which is even better and more rigorous in terms of confounder control. It's always the same message. There is something, there is a risk associated with the use of neuromuscular blocking agents, at least when we use them the way many clinicians do. Manfred, next slide, please.
It's disappointing that we were not able to can show that neuromuscular monitoring has any benefit for respiratory outcome. And as Matthias told, we had the same result with the prospective observational European-wide popular exercise. In a cohort of about 17,150 patients receiving neuromuscular blocking agents, the use of neuromuscular monitoring was not able to reduce the risk of postoperative pulmonary complications. And this was also the case when a quantitative device has been used. And even more disappointing, also patients who were extubated at a TOF ratio over 0.9 did not benefit from this practice. What was the reason for all these studies? We can only suggest that it must be part of the way we do monitoring. And in this context, it's important to note that 87% of quantitative devices used in the popular cohort were AMG devices. I would like to present data from Denmark. Söderström and colleagues asked anesthesiologists and nurse anesthetists via an online-based survey about their experiences with neuromuscular monitoring devices, which again were almost in every response an AMG device. Only 25% of all respondents reported to have problems in less than 25% of their cases. But still 20% complained about problems in more than every second case. On top of the list of problems, they reported fluctuations of the TOF ratio, and number 2 of the list was problems to fix the piezo crystal sensor. In a second manuscript, we analyzed the popular data regarding the neuromuscular monitoring practice in more detail. There were 2 important observations. First, there are still anesthesiologists who extubate patients with a TOF ratio below 0.9. In particular, many were happy when the TOF ratio approximated the recommended cutoff of 0.9. But secondly, and this is in my opinion also very important, the data confirm the figure that AMG overreads the TOF ratio with values over 1.1, 1.0, and this is an idiosyncrasy. This well-known phenomenon, which has been investigated systematically by Liang and colleagues, they compared AMG and EMG using ipsilateral TOF readings. The Bland-Altman plot on the left side of this slide demonstrates that AMG overestimates the TOF ratio dramatically. On the x-axis is the mean TOF ratio of AMG and EMG readings. On the y-axis, the difference between AMG and EMG. And most pairs are positive, which means that the AMG values are higher than the EMG values. The systematic mean bias is 0.4. With other words, measuring a TOF ratio of 0.9 with an AMG device does not guarantee that the TOF ratio is 0.9. It also can be 0.5, and this is still within a 95% confidence interval. On the right side of this slide, I present data from Capron and colleagues investigated the overreading of the TOF ratio of AMG devices, comparing it with mechanomyography. And they present their data with a probability approach. They found that a TOF ratio of 0.9 measured with AMG indicated a likelihood of approximately 40% that it's really over 0.9. The AMG measured TOF ratio must in this investigation 1.0, plus it must be calibrated to have a 97% likelihood that the TOF ratio is really higher than 0.9. Matthias, what do you think about that in terms of muscle function?
Manfred, I think that that we need to remember that not all muscles are similarly sensitive to the effects of neuromuscular blocking agents. So the most sensitive muscles are upper airway muscles, and I will show you an example in a second. And so the most resistant muscle is the diaphragm. So, you know, and we have all seen that as anesthesiologists in the operating room, where when we use, for example, trainer 4 monitoring on the Dr. Paulus's muscle, even though we might have 0 twitches, there might be some diaphragmatic movements, and the surgeon says the patient is breathing and moving, and we said, you know, no, it cannot be true, but it is actually true, because the diaphragm is so resistant to the effects of neuromuscular blocking agents. Next slide, please. So I wanted to show you a video. We have published this like 12 years ago, but it's still an interesting video. It's a colleague of mine. I was also in the scanner, but I show you those his pictures because they're nicer in the MRI. And we had an infusion running with rocuronium, and we titrated that rocuronium to a trainer 4 ratio of 0.8, as you can see on the right side. And the left side is the same volunteer who actually doesn't have a residual neuromuscular blockade. And you can see what happens when the volunteer is asked to take a deep breath in fast, like a spirometry maneuver. And so then there's a physiological contraction of the tongue muscles in order to allow for the high airflow during inspiration through the upper airways. And you can see that this physiological activation of the genioglossus muscle is substantially impaired when the trainer 4 ratio is 80%. And as Manfred has shown you before, there are a lot of patients after muscle relaxation who have that trainer 4 ratio of 0.8. And it has effects on upper airway dilator muscles. Next slide, please. So in the same, Manfred, can you show me the next slide?
Yeah. Yeah, now it's here.
So thank you. So we then 2 years later published that paper where we did not put the volunteers in an MRI scanner, but put little electrodes in the tongue muscle and measured the genioglossus function. Also during a similar stimulation, like a forced inspiration. And you can see that, the critical upper airway closing pressure and also the onset of flow limitation, two variables, were substantially impaired at a trainer flow ratio of 0.8, and did only recover with the trainer flow ratio of 1.0. So that indicates the mechanism. So the airflow impairment that we see with minimal neuromuscular blockade is really due to an inhibition of the genioglossus muscle activity. Next slide, please.
Yeah, Matthias, exactly these results in mind, the Popular team reanalyzed the question if another cutoff for the TOF ratio at which extubation can be recommended may have resulted in an improved respiratory outcome in these Popular patients. On this slide, you see the red line, which indicates the mean adjusted risk for postoperative pulmonary complication, and it's approximately 10.5%. If the cutoff, assuming sufficient neuromuscular recovery, is increased, you can see that the risk of postoperative pulmonary complication decreases. Let's take a look to some specific TOF ratios. Extubation over 0.86 does not make a big difference. The recommended cutoff of 0.9 also includes the mean risk within the confidence interval, suggesting that there is no improved pulmonary outcome when extubated over 0.9. But at TOF ratios above 0.93 and even more at TOF ratio of 0.95, there is a significant improvement of pulmonary outcome. And this is definitely in line with the study you have shown just before. Let's come back to this question if 0.9 is a sufficient recovery. We have done this comparison within the population and compared those patients with a recovery over 0.95 and below at the moment or before extubation. And then you can exactly that the patients with a recovery over 0.95 have a better pulmonary outcome. Taking a look how these patients arrived at this final TOF ratio. The first thing is that obviously using neostig mean reversal, seldomly the TOF ratio recovers to values over 0.95. Using Sugamadex, there is not a big difference between the groups. Both groups have a comparable amount of patients with recovery to 0.95 and below. But here, the observation is that higher doses more frequently allow a recovery over 0.95. Now let's come back to Julia. As mentioned just before, in the PACU, we had a discrepancy between AMG monitored trainer flow ratio, which was about 0.6, 0.62, and the one that the AMG measured at 0.91 and the EMG, which was between 0.6 and 0.7. Julia present weakness and needs oxygen. And due to the discrepancy, we decided to give her a vial of Sugamadex. And then you can see what happened. The EMG recovered to values of 1.0 and the AMG recovered to values up to 140. But even more, what you can see is that the signal was unstable and there was not a clear result of the TOF recovery. Her problems were solved with Sugammadex, and she was able to breathe sufficiently without any further help. The consensus statement that has been referred by Matthias just before come to a conclusion when comparing acceleromyography and electromyography that acceleromyography has a problem of overreading. Julia's case clearly showed us this problem. Therefore, normalization to baseline is mandatory, but not available in most of the monitors available on the market. The most important problem is if the erroneous information, if monitors do not display values over 1.0, nobody knows where the exact value is. Importantly, for acceleromyography, you have to take care that the thumb can be moved freely, and this must be assured. Even the newer devices using triaxial or three-dimensional technology may be less dependent on alignment of the piezoelectric waver. But finally, acceleromyography depends on the quality of control of all these mechanic noises by the anesthesiologist. Quite different electromyography, which is called by the authors of this consensus statement as an alternative gold standard. Electromyography is not affected by changes in muscle contractility. Immobilization of the muscle is not essential, and the preload is not needed. Free motion of the thumb is not necessary, and EMG is less dependent on normothermia. Until this year, however, EMG modules were not available as freestanding battery-driven monitors. But more important than everything else is that we have to acknowledge that obviously a train of 4 ratio is not sufficient enough to guarantee complete recovery. Not only the data from Popular, but also data from Capron, and the data presented by Matthias from his study showed that it's better to have the patient recovered at least to a TOF ratio of 0.95. And very important is that before deciding the extubation or after giving Sugammadex or neostigmine, or even before extubating after waiting or for spontaneous neuromuscular recovery, the effect of every of this treatment must be controlled. Let's come a last time to Julia. Julia is discharged on the 5th postoperative day. The bowel function has recovered fast, and no pulmonary complications have been observed on the ward. And importantly, Julia promises to join the slimming support group in our hospital. Matthias, I think you will give us a final comment on the importance of quantitative neuromuscular monitoring.
I think it is clear based on the presentations here that the only way of ensuring that there is no residual neuromuscular blockade is measuring the train of 4 ratio quantitatively. So I would say, in my personal opinion, it doesn't really matter if you use an accelerometer or another device that measures the train of 4 ratio, but certainly you should measure train of 4 ratio quantitatively. All the devices, technologies have different strengths and weaknesses, but it is important to exclude the residual neuromuscular block at the end of the case, particularly if you have given a high dose of neuromuscular blocking agents. And in order to identify the best drug and the best dose for treatment of residual neuromuscular blockade, you just need that information. So routine reversal with high dose neostigmine, and then go to the PACU and say patient is fully reversed, don't worry. That is definitely not the way to go. And if I hear those things from some very experienced colleagues in my department, I really start worrying.
So, Matthias and Manfred, thank you both so very much for this really excellent presentation. And just looking at the number of colleagues that have joined us, the interest in this topic is really, really huge. And we have numerous questions from the audience. But before we get to the questions, I would really like to tell the people how to obtain the CE credits for attending. Now, as we said before, this educational activity is approved for 1 contact hour. And to obtain CE credits, just go to saxtesting.com/AD. We need to register at the site, complete the evaluation, and upon successful completion, you will be able to print your certificate. Now, once again, support for this educational activity was provided by GE Healthcare, which we would like to thank. And this presentation has been recorded and will be available on demand at advances-patientsafety.org. And the on-demand version will be accredited for CEs as well. But now I would like to come to the questions. And we have had a lot of questions that came in. And I would like to start with Francis, who was actually the first person who sent a question in. Francis asked, has anyone established a safe and reliable approach to reversal with Sugammadex in patients who have 0 post-tetanic twitches at the end of a case when they should not require 16 milligrams per kilogram in cases where a quantitative monitor is not available? Manfred, what's your opinion on that?
Yeah, it's a very deep block, and of course, um, it is possible to reverse this patient, but so far the recommended dose of Sugammadex is 4 milligrams to be applied in a situation in which post-tetanic count is 1. So most probably you need a higher dose, which may be 8 milligrams, and then you can see what happened. But finally, the problem is that for such blocks without quantitative neuromuscular monitoring, it's not clear if whatever you do is sufficient. In my opinion, it's necessary to have a quantitative deep monitoring when you are in such a situation. Otherwise, yeah, you have to carefully observe the patient after whatever you have done, and you have to take care if there is a problem and to be fast if there appears some of these possible problems. Like,
I would agree with you, and I would add the information that obviously 1 molecule of Sugammadex can only reverse 1 molecule of rocuronium, and if you have a train of 4 count of 0 and even with post-tetanic potentiation no response, you really don't know how many molecules are in the body. And I would say it's not safe to just assume that if you give Sugammadex, you will not have run into problems, and you can ensure that there's no residual neuromuscular blockade in this scenario.
Okay, I have another question on monitoring. The question is, when using an accelerometer, we have seen baseline train of 4 ratios way above 100, as high as 147%. Is this expected, and how should we target full recovery when patients have baseline over 100%? Matthias, what's your take on that?
My take on this is first to say it's a known physiological mechanism. When you stimulate a nerve repetitively, the evoked response goes up. It's called staircase phenomenon in physiology. So whenever you really measure strength or acceleration, then that's what you see. It's physiological. It's not wrong. It's just true. That's what what's measured, and that's what the trainer 4 ratio in that specific patient is. My suggestion would be to just try to get a similar TOF ratio at the end of the case.
Great, thank you very much.
Completely agree. This is described as normalization, but so far people have to do it with a pencil. That means you have to have 90% of the 147 and the 147 which has been observed before giving the neuromuscular blocking agents. Yeah.
Okay. I have another really great question, which is almost a philosophical one, and that is, how can we change the mind of old anesthetists that still rely on time of the last dose of muscle relaxants to assess the paralysis? Manfred, would you like to give us some
Yes,
recommendations on that?
I think you have to wait until they are retired.
Well, I don't know. I think it is in general. I'm a hopeful and optimistic person. I think that that we need to embrace that anesthesiologists are not satisfied any longer if the patient survived and has been, sign off in the postoperative recovery room is has been finished. So we need
Yeah.
to get them on the hook for bad outcomes. We need
Yeah,
to
what
hydrate our efforts on quality improvement initiatives and not to let them off the hook. So that's
so
if they just get away with it, it's not going to change. But if we change the
uh,
way we assess quality, we might have a way of improving the
no.
performance.
Yeah, I
So there's
completely
always
agree
hope.
with yes.
Mhm.
No, 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 no. It's always hope. No, and indeed we had done in our department such a thing. Uh, One option is to show people that an incomplete recovery, even if the patient is able to breathe, results in swallowing problems. And if you remember 10 years ago, when we tried to convince our staff members to that they have to monitor every patient receiving a neuromuscular blocking agent with a quantitative device, we came to the result that we showed them that these people have problems by swallowing 20 milliliters of water. This is not really dangerous for the patient, but it clearly shows that patients with a TOF ratio of 80 or whatever are not able to swallow correctly. And doing this in some cases, the anesthesiologists started to believe that it's worthwhile to quantitatively monitor every patient receiving a neuromuscular blocking drug. Yeah.
Great. I have a question from Katrina, which is really great. And she said that Julia is obese. What body weight to use when dosing Sugamadex?
The actual body weight. This is shown in many studies that if you dose Sugamadex according to the ideal body weight, there is a risk that the recovery is incomplete. There are at least 2 cases um, in which obese patients have been dosed according to um, ideal body weight, and there was a clear observation of reoccurrence of block. So yes, you have to dose according to actual body weight.
I have another question that relates to Julia. Thomas asked, does previous administration of neostigmine affect the pharmacodynamics of Sugamadex administered after in the case of Julia?
But yes,
Matthias, wie
No, no, I don't think so. I mean, it's an independent mechanism. Um, neostigmine is an acetylcholine esterase inhibitor, and Sugamadex is an encapsulating agent. Sugamadex does not encapsulate neostigmine, so for sure not. And so I would say there are additive effects.
Okay, good.
yeah.
Matthias, I have another question for you, which was asked by Dennis or Denis. Does it make sense to administer reversal drugs in every single case of usage of NMBs?
No, No, I mean there is. So this is really this seminar is supporting the use of quantitative neuromuscular transmission monitoring. So the statement in turn is, if we have arrived at the preoperative trainer 4 ratio, that is an indication of absence of neuromuscular transmission disturbances, at least as far as the effects of non-liberalizing neuromuscular blocking agent goes. So therefore, if a patient has preoperative values of trainer 4 ratio, there's no need to reverse, and there's no free lunch. Each medication that we add has side effects, and we should not use a medication in a patient who does not have an indication for the medication.
Would you maybe like to elucidate a bit further on what happens to patients who receive neostigmine after they have fully recovered? Is that really a problem?
Yes, we have done several studies. We have volunteer studies, and we have done studies, basically observational studies on big cohorts of patients, and all of and others have done similar studies. So, neostigmine is actually an effective drug that increases the concentration of acetylcholine at the postsynaptic membrane, and it reliably leads to muscle weakness if you give it to patients who don't have a residual neuromuscular blockade. And since we are not measuring it, the train of the neuromuscular transmission quantitatively, just the routine application can lead to two unwarranted things. So first, it can lead to incomplete recovery, which Manfred has spoken about. And the second is that in the fraction of patients who only received maybe a low dose of non-depolarizing neuromuscular blocking agents, and it can induce a depolarizing neuromuscular block. And that's not a myth. That is clear that this is a side effect of neostigmine. Not to talk about the muscarininergic side effects on heart rate that I had spoken about before.
Another maybe a bit provocative question by Christina again. When Sugammadex comes into routine practice, and I assume she means when the prices may be lowered, aren't we going to cease this endless debate with surgeon and about residual neuromuscular block?
Of course, if you have a very effective drug that can be given at each level of residual block, and if I expect in that future that we will use Sugammadex and will give another vial if it's not sufficient and so on, finally we can help surgeons to improve surgical conditions. It's very interesting, the discussion about improvement of surgical conditions started exactly in that time when Sugammadex became available in Europe in 2007. The time before, there were in the literature exactly three studies looking for surgical conditions in the context of neuromuscular block. So I think this is of course related to each other. But our message today, I think, is whatever you do, it's important to control what you do. And control means to measure and to act according to what you have measured. And that's more important than the question if you use Sugammadex or neostigmine or whatever. I think this is
Okay, thank you very
for the
much.
both of
I have another question. I have a question from Jennifer. And she says, I've worked in and visited several hospitals. None of the hospitals had relaxometers on the ICU, although many patients get to the ICU with relaxation just before the transfer to the ICU. Do your ICUs have relaxometers? Matthias.
It's a good question. So that's the next little project or series of projects that we have to move towards. So to make sure that the patients who are in the intensive care unit are extubated and are not suffering from residual neuromuscular blockade. So we have in our cardiac ICU, whereas the biggest problem is in cardiac, where some anesthesiologists still think they need to give like 50 milligrams of rocuronium for the transport to the ICU, which I think is ridiculous. I don't think there is any indication for this. But let's say people do this, then we need to make sure that the patients who are on fast track in this cardiovascular ICU are not partially paralyzed. And we have a process that we have written down that it has to be measured. Is that always the case? No. We don't, for example, have here at neither at Mass General, not on Beth Estral Deaconess, we don't have those implemented routinely in other units. Well, I would say, the traditional routine of extubating patients in the ICU also ensures that patients are not residually blocked at time of extubation, because there are so many delays in extubating patients in the ICU. So in most of the cases, I would say patients are not getting extubated within the first 2 hours, even though it should be more frequently the case, and it should then be measured.
Okay. Manfred, just a
We do,
short answer.
we
Yeah,
had,
just
yeah, we do have a different approach. We define that the patient that has to be transferred to the ICU from the PACU or from the OR in an intubated mode, that this patient has to be a complete recovery before transport. So
Oh, good.
we exclude residual block even in intubated patients, because the OR has neuromuscular monitoring and the ICU does not.
Right. Well, I have another question. I just wanted to say beforehand that we had a lot of questions that started with a thank you to the two of you for this very informative session. So I just want to pass that on to you. And Kareem asked, speaking of science and studies that are ongoing, do you know of any ongoing neuromuscular monitoring studies that we should look out for in the next few months? And if yes, what are they focusing on? Which I find is a great question.
Yes. Manfred, do you want to say something?
Um, it's not a good idea to talk about unpublished work, in my opinion, because there are two options. The reviewers believe or the others do not. And finally, now, yes, we are working on the precision of neuromuscular monitoring devices, precision to predict complete recovery based on some curses, but I think it's not ready to discuss it in the
I thought
public.
maybe
Yeah,
Matthias
we
wants
have.
to loop in on Calamari.
Maybe. Yeah, well, that's one thing. So we have, as Heidi had mentioned initially with the disclosures, I have the patent on a reversal agent for both steroids and also benzoyl which we still are working on and currently in licensing contracts. That's one little thing, but that will take a little while until it's on the market. And then the other thing is we are looking into the other ways of getting more confidence in our observational research data that indicates the problems of muscle relaxants on postoperative outcomes. And we are currently finalizing instrumental variable analysis study, which underlines the same problems, just with maybe more a little bit sophisticated methods. And then we are also looking into, ways of implementing decision support in the electronic anesthesia record. So since, the anesthesia providers are not really doing their thing, so maybe we can highlight them with decision support tools that helps them identify high-risk patients. That's another project which we're doing.
Great. Matthias, thank you very much. You mentioned fast track before, so I have one question that fits into that, and that is that Margaret asked, can NMT play a role in optimizing ERAS principle? So the early recovery after surgery principles. What's your opinion on that?
Absolutely. We should partner with the surgeons and request that the surgical interns ask what the train of 4-ish is.
Okay.
That would be great.
Fantastic. Now, it's almost the top of the hour again, so I think at this point in time, we really have to come to an end. We had a really great and very active audience, a great participation, and a lot of really fantastic questions coming in. I would still have another 10, 20 questions that could be addressed, but unfortunately we're running out of time. So as always with the webinars such as this one, it's impossible to answer all of them. However, I'm really happy that we were able to address a lot of the issues. And at this time, Tracy, I think, has a few concluding remarks. Tracy, please.
Thank you, Dr. Leewald, and our speakers today. Immediately upon the conclusion of this webinar, you'll be presented with an online survey. Please keep your web browser open, and we appreciate your feedback. In 1 hour following the conclusion of this webinar, you'll receive an email with instructions and this link to obtain your CE credits, saxtesting.com/AD. And on behalf of Sachs Healthcare Communications, I would like to thank our speakers, GE Healthcare, and the many people in our audience today. And this concludes our presentation today. Thank you.
Thank you.
Thank you. Goodbye.
Thank you very much. Bye-bye.